Welcome everyone to our webinar this evening on the Human Medications Regulations and the Consultation on Extending Medicines for Optometrists and Contact Lens Opticians, which is quite a mouthful. We've got an expert panel who's going to give some updates on the work to date around the proposed changes and how these might impact on you as registrants, your work in practice, and perhaps as a practice owner. At the end of this update from our colleagues, there's going to be time for questions and to share comments and discussion. But I would add that if you do have any questions during the course of my colleagues updating you, please just ask them and pop them into the questions box. And what I'll do is I'll pick them up towards the end of the presentations, and then we'll go back and ask the panel to comment on those as well. I'd like to introduce everyone first of all. I'm Max Helford, I'm the Clinical and Policy Director at the Association of British Dispensing Opticians, ABDO. With us tonight also is Peter Hampson, the Clinical and Policy Director for the Association of Optometrists, Paramdeep Biku, Clinical Advisor to the College of Optometrists. We have Dean Dunning, Head of Qualifications and Chief Contact Lens Examiner for ABDO, and Alex Webster, Director of Professional Development at ABDO as well. And also Steve Taylor, who's a professional advisor to FODO, the Association for Eye Care Providers. So to start off the evening, kind of welcome Peter, and just ask you really to give us a bit of a background information and progress to date on the consultation.
Thanks, Max. So I'm going to open up, but I'm going to open up in a slightly odd way. I'm going to hand off to Steve quite quickly, and then I'm going to talk a little bit more. So this has been a long-standing piece of work, and it's been rumbling in the background for a long time. I've been attached to it for getting on for 10 years now, to give you an idea of how long it's been going on for. But actually, it goes back a little bit further than that, which is why I'm going to hand over to Steve, because he was around at the beginning of some of this original piece of work. So, Steve, if you want to just give some of the deep history on this first, and then I'll pick up from there.
Okay, yeah, you're right. I'm older than the rest of you put together, probably, but the College of Optometry used to produce a formula, and I was involved in that in the 1990s. And then we had the Crown Report came along. The Crown Report was designed to look at independent prescribing, and the college was very much involved in developing that. Once the Crown Report came out and optometry was listed as as an independent prescriber possibility, things changed a little bit. At that point in 2005, there were some changes to medications or drugs available. For example, I remember the days of using atropine and of using pilocarpine, which were removed in 2005. To put it in context, in 15 years of practice or more, I'd only used atropine half a dozen times and pilocarpine once. It wasn't as though it was a big loss, but it meant that things had changed a little bit. Then when independent prescribing came in, a working group from the AOP, FODO and the college were looking at how they could extend the range of drugs to other groups other than just the independent prescribers. And within that working group, we had a whole pile of people. To mention a few, we have Bernie Gilmartin from Aston, John Lawrenson from City, Nick Rumney, Trevor Warburton from the AOP, Kevin Wallace from the AOP. And what the working group identified was that many of the drugs that were available were actually out of date and couldn't get them. So there's no point in having them on a list, and therefore it would be worthwhile reviewing the list. And in 2016-17, the Optical Confederation, as it was then, with all the different parts working together, came up with a report that it was going to submit to the Department of Health in a draft form. And I think that's really where Peter and the AOP took on the lead, and Peter has worked really hard since then to make what's happening today actually happen. And that's really how long it's been. It has been more like 20-25 years to get to this point, I'm afraid. Peter.
Thanks. So yeah, I think it's important to have that history, because most of these things don't happen in isolation. It takes a group of people to make things happen. It's rarely just one person. So we all work together, hopefully, and make things happen. And as you just said, this piece of work has been rumbling on now for a good few years. It's been weighed down by changes to government, changes to we had a pandemic, we had Brexit, we had all of these things, and it's each iteration of when we think we were going to make some steps. They got pulled back by something moving around us, and that's something beyond our control. I think it's really important to recognise how hard change can be sometimes to actually get something across the line to move the profession forwards. So I think this is a really good opportunity for us to do that, and hopefully these changes will really update what all of our colleagues can do, and some of my colleagues on the call are going to talk about that in a moment. But the process as it works through will make some changes hopefully to the human medicines regulations, and within those I'll set out some exemptions, and those exemptions basically say what we can and we can't use. These changes will update that for everybody, and hopefully that will mean that we can all do a little bit more in practice. But it is quite hard work. It has been a lot of hours to get us to this point, but I think we genuinely do have an opportunity to make a change that we can think of as a generational change for the professions, and I think that's really important. And that change in regulations then, once this consultation is complete, hopefully, still has a number of steps to go through. It's not a done deal. The consultation is basically getting the views of everybody, and if the views are positive, and that's why it's so important that people take part, we can then, or the government can then work through the next steps, which are getting the regulations in front of Parliament, getting through the parliamentary processes, and then hopefully, if all of that goes to plan, we'll see some new legislation sometime next year with a bit of luck, and then we'll all have a new range of sort of core base entry-level practice for all optometrists and contact lens opticians. I think that's all I probably need to say, because I think Paramdeep's going to talk a lot about how important these changes are for optometrists. So Paramdeep, I'm going to hand over to you and let you pick up the baton.
Paramdeep, you're muted.
Oh, I'm very sorry. Oh, there we go. But yeah, I just want to say thank you for Peter for the introduction, and I just want to start by saying that the announcement by the DHSC to propose to extend this list of exemptions for optometrists and dispensing opticians is actually nothing short of an absolute milestone for the eye care professions, and recognising the important role that we all play in providing eye care and how they've evolved over the years. Now, in terms of the impact, these proposed changes have the potential to enable optometrists to provide much more care within the high street practice, meaning the benefits to the patients in terms of convenience in accessing these medicines. Now, as Peter's already mentioned, this can actually help reduce, unnecessary appointments to the patients, so they get into the GP to get a prescription, and in turn that can help reduce referrals to the hospitalised service, and then free appointments for those who really need to be seen in those settings in an already precious service. So, we want to ensure that the patients recognise their local optometrist as their first point of call for eye health needs, and that we're moving towards becoming a much more therapeutically enabled profession amongst other professionals as well. So they can also help with signposting and ensuring appropriate referrals. Now, we all know that across the UK, optometrists are already diagnosing and managing patients with many common and non-sight-threatening eye conditions within primary care commission services or even privately, and such as infective and allergic conjunctivitis, blepharitis, dry eye, superficial injuries, and they've been supported by the regularly updated and evolving clinical management guidelines. But one of the key issues is we're facing a significant limitation in accessing the relevant therapeutic agents to manage these effectively and conveniently. So what happens in the current state, by referring to the GP to simply access the medicines, this means they become the responsible clinician for the patient. But in my view, I like to argue that they don't actually necessarily have the relevant expertise to do so. So although we know from several studies are actually very, very welcome, the GPs very much welcome these referring common eye problems to optometrists, and also they actually have a lot of limited access to equipment or are lacking confidence to make a formal diagnosis. So taking on that responsibility can be quite a challenge for them. And that said, very few GPs have the experience of using that equipment either. So even if they did have access to it, they don't use it very often. So it makes sense in my mind that as an optometrist or an eye health professional, rather than a GP, should remain the responsible clinician for managing that person's eye condition as a registered eye health professional. But to paraphrase a really known well quote, with great medicines access privileges comes great medicines use responsibility. So although optometrists can legally supply these medicines without prescription, doesn't necessarily mean that they should unless it's within their scope of practice. And we'll talk more about that as we go on. So in our view, that these proposals would mainly likely to and have immediately have a benefit as optometrists and eye health professionals working in these acute eye care service settings in primary care, secondary care, or community, who are much more likely to have relevant knowledge, expertise, and experience to manage these range of eye conditions, and particularly those which are very, very common and non-sight threatening, which commonly present in primary care. And now you may have seen some work that we've done over the recent months, that we've published a policy report about reviewing the MECs and Q schemes within England, and optometrists services have shown that can safely and effectively manage these conditions without referral in over 70% of cases, and including within Qs, that's often without any further training. But where they are referred to the GP, that's overwhelmingly just to access the medicines. It's not normally to provide any further investigation or management. It's just simply to get a prescription for the treatment. Now, in terms of the specific treatments, if we look to the antibiotics that optometrists currently have, we currently have two that have access to. That's chloramphenicol and fusidic acid. Now, while they're indicated for bacterial conjunctivitis, we know they're not actually as effective as those bacteria implicated in conjunctivitis associated with contact lens wear, and they are normally typically gram-negative species, and fusidic acid also prohibitively expensive. So that means agents with a gram-negative activity should be used instead in those cases. And in that, where those situations do arise, bacterial conjunctivitis is very common, we have to then refer to the GP to get the right medicine. So that is why I'm really pleased to see gentamicin being added as a proposed medicine for optometrists to access, and that's a broad spectrum aminoglycoside, and that would be very welcome, as we know that conjunctivitis, as I mentioned, is very common, and contact lens wearers are likely to present there in the first instance. So, you know, in turn to having an alternative antibiotic to help reduce the risk of antimicrobial resistance that would otherwise be brought about by overusing a particular drug class such as chloramphenicol. Now, in terms of the extensions, they not only help provide more appropriate use of topical antibiotics, they also enable access to prescription-only versions of the already available pharmacy-only medicines. And in my mind, that's the most obvious one is sodium chromoglycate. Now, in the P-only form, that can only be used for seasonal or perennial allergic conjunctivitis, and it cannot be used off-label. But in POM form, prescription-only medicine form, it can be used off-label. So it can be used for managing other common and non-sight-threatening allergic conditions, such as contact lens-associated papillary conjunctivitis and giant papillary conjunctivitis, if it's caused by exposed sutures or a prosthesis. In addition to other anti-allergy preparations from antihistamines and mast cell stabilizing drug classes, there's another addition that being proposed that I think is quite noteworthy, and that's diclofenac. Now, we know optometrists are delivering post-operative cataract service care across the UK, and many people present to them in the first instance, and possibly with complications such as cystoid macular edema. So this could be used as an adjunct treatment to topical steroid therapy prior to referral either to an IP colleague or local hospital eye service, provided they follow local protocols and they involve the provider in the first instance. But it has a wide range of license indications, so that's why I'm quite excited about it. And I feel it's really more likely to play a role as an alternative for mast cell stabilizers in allergic eye disease where they're not being effective, and also in providing pain relief and anti-inflammatory therapy in superficial injuries like corneal abrasion. So it really is adding to the armory for an optometrist to help manage the pain. Now, we know that there's some debates across the US and the UK about whether or not we should use topical analgesics such as an anesthetic, which we know can be quite detrimental. So this will help to bridge that gap. So rather than referring for an opioid analgesic, for example, such as a cocodamol, we can then provide an anti-inflammatory therapy through an NSAID, which can also manage the pain. Now, we can also see from the proposed medicines list that are they're actually either within the same or similar drug class, or those already within the existing medicines exemptions list, but those are mainly in the P-only form. And some of the medicines on the list, such as atropine and pilocarpine, as Steve already mentioned, are actually being reintroduced to the exemptions. So they're not unfamiliar to the overarching theme that these are established medicines with very good safety profiles, and they're primarily indicated for common and non-sight-threatening indications. So with changes in practice and the introduction of enhanced services over the years, optometrists already have, you know, the understanding to enable them to provide these medications in terms of their pharmacology, contraindications, cautions, and that supports their safe and judicious use. But to put this into practice requires all clinicians to identify any gaps in their knowledge, experience, or practical application, and to address those gaps accordingly before you start to use it. The analogy I like to give is when you go to see the GP has an access to a huge range of medicines and they're always changing all the time. And so they need to make sure that they are familiar and understanding about that drug before they start to prescribe it. And this will go for any clinician, optometrists and dispensing opticians, no exception. So, so we can see these changes, if they do go ahead, will significantly impact clinical practice for optometrists, and that will enable faster and more effective treatment of eye conditions that they already know are managing in primary care, and by increasing the range of non-sight-threatening eye conditions that can be managed without further referral. So that can also in turn reduce the referral and relieve pressure on the GPs. But it's really, really imperative to make sure that we're using these medicines, they're within your scope of practice, and to ensure that they're used safely and effectively, particularly when moving into a new area of practice. So I'd just like to, I think that's a whirlwind overview in terms of the impact this could potentially have for optometrists. So I'm going to hand over to my colleague Dean, who's going to talk about the impact potentially for dispensing opticians and contact lens opticians.
Thanks, Pamdi. I think one of the key things that you mentioned there was scope of practice, and I think sometimes the word contact lens optician almost limits us. They sound like just contact lenses, but actually a contact lens optician is very much an anterior eye specialist, and their ability to be able to diagnose, some of these conditions, be able to treat them, will have an impact on waiting lists and so on, everything that you mentioned earlier. So definitely contact lens opticians can play a part in this. What I wanted to discuss was what does that mean for the people who are training to be contact lens opticians, because obviously this change in legislation will mean potentially a change in the sort of drugs that they've been used to and been learning about before. I'm just going to try and share a slide with you, if that's possible. And this has happened at a perfect time for contact lens opticians, because we recently had a review of the whole education system. It happened to optometrists, dispensing opticians, IP optometrists, contact lens opticians, where we've moved from very quite rigid competency-based assessments to outcome-based. And that, I've listed a few there. If you look at, I'm not going to read them all out. It's pointless to read them out. It's very boring. But I think what's clear here is the mentioned scope of practice of our current legislation, allowing us to move with the times, because we know we're in a very sort of technology-enabled industry. We know that things moving on, and as we've already mentioned, there's drugs now that were removed from the list that aren't manufactured anymore, but also some of them have come back. So it's making sure that we're aware of what the current practice is, what our current scope is, and that we're able to run with legislation sort of quickly. So that's what we're doing with our contact lens diploma. We launched a new contact lens diploma in 2024. We launched a new syllabus for it, and that syllabus very specifically was designed to be able to move with times and changing legislation. So in terms of that part, we cover it in 2 different areas within the syllabus. There's 6 units in the syllabus, and we cover this element twice. Again, I'm not going to read out the syllabus, it's just there for it, but we demonstrate it theoretically. We also demonstrate it practically as well in our exams. It's all part of a spiral curriculum to make sure that anybody learning to become a contact lens optician is fully trained both in the theoretical knowledge of these drugs and in the practical application of them. So my job's been actually really quite easy. When we saw this legislation, does our education system, how we're training contact lens opticians, does it move with that? And it's a resounding yes. I think we're in a really good position for anybody training to become a contact lens optician can be rest assured that they will be able to integrate this into their scope of practice quite quickly. What it doesn't quite capture necessarily is those who maybe did train underneath that element before the syllabus change. So if they did work on the previous syllabus, which was 2019, or some of the early ones, 2015, 2008, and so on. So what I'm going to do is hand over to Alex, who will be able to sort of talk you through what that means to other contact lens opticians who have trained before 2024.
Okay, let me just share my screen if I can. Okay, so as Dean's just said then, my role within ABDO is looking at the continuing professional development. And really, I've put up this slide, it's already been mentioned about scope of practice. I think it's really important to just remind everybody that all GOC registrants have the same standards of practice, whether you're practicing as an optometrist or dispensing optician, or as a dispensing optician on the specialty register, as a contact lens optician or the IP optometrist. We all have the same standard of practice, and in that we are expected to keep our knowledge and skills up to date. So once you've had that qualification, you're no longer doing that new syllabus or whatever it is, you're out there working in the field. When these changes or any other changes within our clinical practices happen, it is our responsibility to keep ourselves up to date, to understand those changes if we are going to be practicing in that. And there's also an element there to obviously be aware of how practice is changing. If you haven't qualified, you know, if you're 20, 30 years into when you qualified, we've always got to be aware of how our practice is changing anyway to make sure we are kept up to date. The other side of it then, which is on here, is our standard 6, is to recognise and work within your limits of competence. There are limits of competence related to your qualification. There are limits of competence which are legally bound by the Opticians Act, for example, but there's also limits of competence related to your knowledge and skills and experience and confidence as well, and we all need to be able to establish that individually. And we need to understand and identify when actually that's not something for us to do and that's something for us to refer on. And this really comes down to making sure that when, and hopefully the legislation, the regulations change and this becomes available, as a qualified contact lens optician, we do understand that we need to undertake CPD to be able to work with these medicine changes. We need to be able to go and revisit where we were originally at, what our qualifying level of competence within ophthalmic drugs was, what our understanding was then, and then where these changes have happened before we go on and use in our practice. And so regarding that, obviously it is the fact that CPD will be available. We have a very wide range of CPD formats that we provide currently out to dispensing opticians and contact lens opticians, but particularly where we're thinking here, we have e-learning modules and recorded lectures which will be available, and further down the line and ongoing, because obviously it's the understanding that yes, regulations will change, but it is that constant keeping up to date with the clinical practice. So, you know, taking part in interactive webinars and peer reviews and practical skills workshops related to this ongoing throughout your practice is also very, very relevant. Also mentioned here that there are professional development courses. So obviously MEX, where we're considering things like foreign body removal and GAT. If you haven't had that training, we shouldn't be sat in practice doing these things. The contact lens honours course also will be available, and again have those higher level of practice for the CLO within that. And so what will be available on changes is really revision CPD. And as Dean's already said, this is actually already within the qualifying scope of the contact lens optician. Ophthalmic drugs is already in there from a theoretical and from a practical examination perspective, but the revision will be keeping people up to date with those changes. And within that, there's that revision on what we're considering here. For example, conjunctivitis, revision on our infection control practices, revision on anaesthetics, but with those up-to-date changes taken into account. So I think that's it for me regarding that. I'm going to stop sharing my screen, and I think it's time for me to hand over to you, Max.
I think we were going to hand over to just Steve to come in and perhaps give a little viewpoint from the practice point of view, Steve, really.
Yeah, that's fine. I think the title I was asked is Positive Changes for Primary Eye Care, and to some extent I'm going to just go a little bit over what's been said already before I do that. I mean, the services for contact lens opticians and for optometrists have developed remarkably over the last 5 to 10 years. So you've got increasing dry eye assessment and management, increasing design of MEX and similar services. You've got development of myopia management and refractive changes, monitoring services for diagnosed eye conditions, post-cataract services, and then you've got the IP management of eye conditions. So the whole world of optics and optical practice has changed incredibly. What the latest changes are likely to mean is that you've got better management for bacterial and allergic external ocular conditions, because you've got access to more drugs to be used. You've got additional methods for dealing with chronic dry eye. So there are new drugs on there which we wouldn't have had before, which will help enormously with that. There's more flexibility for refractive assessment of children. The atropine, and I know I've mentioned this before, the atropine that you've got access to at the moment is for refractive purposes. But if you get that onto your drugs list, then as things develop, particularly with maybe myopia control, if you've got access to atropine, it's more likely you can change the usage than it is to try and get access to it without having it before. So this whole change is really important for what goes on in the future. Also, you've now got the opportunity for an emergency action when there's acute glaucoma. As I said, I had that early on in my professional life with pilocarpine. Rarely used it, but it is nice to think you've got it there if you ever needed it. And for contact lens opticians now, the access to anaesthetic means that you've got more options when you're dealing with fitting hard contact lenses or scleral lenses or whatever. So all of these are really major changes in the way we practice and the way we can practice. The next stage from this particular webinar, I think, well, there's several big stages, but firstly, we want to ensure that the professions as a whole support the changes, and therefore individuals are prepared to take on additional responsibilities where they take up the service, but also to recognize that even if they're not going to do this themselves, there are other members of the professions who are going to do it, and perhaps they can support by filling in the documentation on the consultation to support that. Access doesn't necessarily mean that drugs need to be used. So the fact that you've got access to it doesn't mean you have to go out, buy it and use it the next day. You have to understand what your role is, what you can and can't do with it, and what your limitations are. So training and training courses are going to be very important for the future there as well. You're going to need to brush up on how you write a prescription order. Don't do it very often at the moment, because a lot of it, well, not a lot of this, but certainly some elements of this require you to write a prescription for the patient to take down to pharmacy. And if you haven't done that before, haven't done that for a long time, then you definitely need to be looking that up now to do it. But I think you have to recognize that this is a very significant step towards recognizing the skills and the knowledge in both CLOs and optometrists, and it's taken a very long time to arrive there. So I would again really ask you all, wherever possible, to demonstrate support. The consultation document, you probably don't need to read it anymore, because this webinar hopefully will have taken through all the things that are in there, but just go to the end point where it asks you, do you agree or disagree, and please agree that it would be useful to have this available to all the people working in optical practice on the main front line, because it really is important. Anyone who is in IP and has IP qualifications, this doesn't interfere with that at all. This is totally different, really. It does overtake AS, but not IP, and AS was recognized as perhaps not being as fit for purposes it might have been very early on after it was arrived. So anyone at all who works in practice, if you can go onto that consultation document, please do. I think that's it, Max.
Thanks, Steve. I think that's really helpful, and I will endeavour to share the link to the consultation in a moment, where I figured out how I actually can do that on the questions box, but I'll probably look to my colleague Sue to help me with that in a second. I think it is really important. Thank you to all my colleagues who've kindly shared those updates, and I hope everyone's found them useful. It is really important that we take this opportunity to respond to the consultation. It doesn't take very long to go through it, and to show positively from eye care professionals across primary care that we feel we are well placed and able to help more patients by having access to this increased range of medication. There has been a couple of questions coming in. I'm kind of hoping that I'm going to direct these in the right direction. If I ask you a question and you feel, perhaps I've asked the wrong person, I'm looking at my colleagues, please do feel free to bat it towards another person. But So one of the first questions came in, would I be able to sell or supply these new exempted medicines rather, from my practice directly? Apparently, can I direct that one to you, please?
Yeah, absolutely. So actually, under the existing legislation, the exempted medicines, they can be supplied routinely via a signed order from a pharmacy, but in theory, they could be sold or supplied directly to your patient, but only if the situation was deemed an emergency in the course of your professional practice. It's up to your professional judgment to decide what would actually constitute an emergency, and also several considerations that would actually influence your decision. That includes the practice location, rural versus city, and also the access to healthcare settings such as local pharmacies or hospital emergency eye department or A&E. But in my view, these instances are likely to be quite few and far between. You know, to give an example of an instance where it could be deemed an exception, is that if a patient attended with a corneal abrasion and actually high risk of infection in a rural setting, and in that area is actually quite a limited access to a pharmacy, or if it was closed, for example. So in that situation, then a broad spectrum antibiotic such as gentamicin could in theory be supplied in an emergency. But conversely, if the same scenario occurred in a city location, you know, with several pharmacies that are open in close proximity, there's a local A&E department down the road, you know, it's much more difficult to justify in that situation if that's an emergency. So in that route, you're right, it's probably better to go via the pharmacy. You know, another example would be where a patient with an episode of acute angle closure glaucoma, as Steve's already talked to, following pupil dilatation in a city location with an access to local eye casualty, and where despite having access to pilocarpine in the practice, to reverse the mydriasis, it might be more appropriate to follow a local protocol or a route to refer directly to the specialist management without intervention. But in any case, emergency or otherwise, good prescribing, or in this case, signed order supply, the good practice actually dictates that wherever possible, the act of recommending a drug and supplying the drug, which is known as dispensing the drug, should be separated wherever possible. And that allows you to become much more objective in your judgment about whether to prescribe or not to prescribe. Otherwise, it can actually be deemed as risking over medicalization of the eye condition, over prescribing, not to mention restricting the range of medicines available. You know, for example, where the formulation or product type might not be optimal or even contraindicated, such as known preservative allergies, and that would actually potentiate the symptoms anyway and require even further management. So from that perspective, there are actually quite a few instances where a true emergency will actually occur in a practice, but it is down to your professional judgment. You know, there's also some practice considerations as well. So I don't know if Steve, if you want to have any thoughts on that, about, you know, balancing the need for having access to the medicines versus the likelihood of actually using them in an emergency scenario.
Yeah, I mean, I think when I said I've only used the pilocarpine once, the reason for that was that most of the consultants in the area I was working said, don't put pilocarpine in because we can't then assess the patient properly. You know, it'll only take you a couple of hours to get them down here. We prefer to see them with the glaucoma than we would with the pilocarpine in. So I think it is a question of really using your experience and your knowledge to decide which patients you can and can't see appropriately. I think the other thing I would say, following on from all the things you've said there, is make notes. This is really, really critical now. When you're going into these areas where you're making a decision as to whether it's emergency, non-emergency or whatever, please make sure that the notes that you record are full, extensive, because if anything goes wrong, it will be coming back to make sure those notes actually match what you've done and that you can support the action you've taken.
That's great. Thanks, Steve, and thanks, Pandu. A question, well, a couple of questions have come in regard to training. So I know we've got a few people on the call here. So perhaps, Alex, you may wish to just start with an answer and pass it on to other colleagues. But where can I go to find more information, resources to support my learning or training to ensure that I'm using these medications appropriately? So, Alex, perhaps if you wanted to pick up, for say, from a contact lens optician point of view, and as would Dean, I guess, as well, and then over to Paramdeep to give a perspective, perhaps from optometrists, along with perhaps Peter.
Yeah, I mean, obviously, as I've mentioned, ABDO will have training available for all members. I know that covers the majority of contact lens opticians in the UK, but not everybody. This is something that has been discussed as part of this process as well. So it will depend It will depend on the outcome of the consultation as to how people who are not members of ABDO will pick this up, but obviously most people are going to be members of ABDO or FODO, and obviously you know, there's discussions to be had there, but certainly ABDO members will be able to access free of charge, as they currently do, relevant CPD. And as I said, we would make that both distance learning, which is available to everybody at any point that they want to access that, as well as interactive learning, where we can have some more deeper conversations, skills, things, that type of stuff, but obviously is a little bit more restricted on when people can access those types of CPD.
Dean, is there anything you wanted to add really with your educators, the content and students, etc. hat on?
Yeah, I think I want to emphasise that for anyone student or learning that trade, it'll be embedded pretty much immediately from the legislation being changed. That syllabus allows that for us to really fluid with it, to make sure that the learning takes place. We will offer support for any students who are in that sort of preliminary area who we get to take examinations when the legislation changes, that sort of short window where they may have finished their education but they're waiting for exams and so on. If the legislation changes, we'll offer support to those students via our partner colleges.
Okay, Paradine?
Yeah, so I think for optometrists, the main resource, you know, to ensure that you're making an appropriate and sound clinical decision would be the clinical management guidelines, and they set out some evidence-based recommendations for a wide range of eye conditions therapeutically and also non-pharmacologically as well. At the moment, there are about 60 available. I think they're increasing over time. And while they're directly aimed at IP optometrists initially, we know that they're actually being used by other health professionals and those clinicians who are non-prescribers as well, because they're available publicly. And, you know, we know that the management for some conditions could be managed with the inclusion of the extended range. As I mentioned earlier, it's important to work with your scope of practice. I think we've all talked about that, and that holds true for any clinicians, IP or otherwise. And so what I would direct optometrists towards is a resource that we produce called the Expanded Scope of Practice Guidance. And we set out 8 key principles to consider before moving into a new area of practice, if you're not familiar with that. Another resource which I think is probably more pertinent, which we also help to co-produce, and we actually endorse as well, is the Royal Pharmaceutical Society's Expanding Prescribing Scope of Practice Guidance. So while that's centered on the act of supply via prescribing, the principles of how to do that to increase the range of medicines available to you or moving into a new area of practice are actually very similar, if not the same. And this actually sets out a series of practical and achievable targets or steps that you can address any gaps that you've identified. And as Alex has already talked about, it's really important to recognize your own skill set, your own limitations, and to identify where you need to improve. And so I'm very confident, as Alex already attested to, that within the eye care sector as a whole, we'll produce these very timely and relevant CPD resources, and they'll be developed in due course, I'm sure. And I'll really strongly encourage everybody to consider adding these potential learning outcomes to their professional development plan. And that can really help support them to use these medicines appropriately and safely.
Apparently, there's been a couple of questions actually, because you've just touched on it, and it is about, you know, should I still bother undertaking my IP qualification? You know, and there's a couple of different ways it's phrased. So apologies if you asked that question, but in a slightly different way. But I'm kind of grouping them all together, and I think that's the general gist of the question.
Yeah, I think it's really important to remember that the license indications for these medicines being proposed in the extended list are primarily for managing common and non-sight threatening conditions such as allergic eye disease, superficial trauma, and superficial ocular infections. Now, although they could be used off-label too, they wouldn't be appropriate to manage the more severe presentations or potentially sight-threatening or even life-threatening conditions as well. Things like preseptal cellulitis, anterior uveitis, you know, and the various different forms of keratitis. And they actually require things like topical steroids, fluoroquinolone class antibiotics, antivirals, or even oral prescription only medicines such as coamoxiclav. So there still be an absolute need for IP optometrists to enable to manage that area of care. And I'd really like to see this extension to the exempted list upon qualification as a stepping stone to encourage them to undertake IP in the future. And also there are areas of practice which are outside of these acute eye services, things like glaucoma care and shared care. And that would require an IP qualification and a glaucoma qualification to manage those patients therapeutically. So there's definitely a need for IP qualification to manage those additional cases. And there's actually some research that we found that where these acute eye services involved IP optometrists, the proportion of people being able to be managed fully within primary care without referral increased from around 70% to well over 90%. So there's definitely a role for IP still to be played.
Thanks, Paradeep. I'm going to possibly address the next question. I've grouped again a couple of these together to Steve and Peter because of your involvement with the actual consultation. But it's like anything, isn't it? You put a list out of things that are hopefully going to come available, and colleagues think actually it would be really handy if we could add some other medications into this list as well. So I'm addressing Nima's question and Andy's question in there as well. Would you like to comment on kind of where we've arrived at this list and why we've arrived at this list? Paradeep's obviously touched on it just there, that an opportunity for the future, but it's really more about where we are today with this consultation.
I'll leave Peter to answer that one, I think.
Thank you. So the original list of medications, it's taken a couple of little bits of revision. The original plan from the original working group was literally to cover off some of the medications that had disappeared, to widen the scope, as others have talked about, so we weren't sort of susceptible. I think Paradeep was talking about fusidic acid becoming really expensive at some point. That makes it really difficult for practitioners then to have options for how they treat patients. So the first big thing was, let's solve some of the problems around being really stuck with not being able to get access to things. That's where the extra antibiotics came from. Then looking at treating bacteria that are resistant to certain medications. So that was added into the list. And then looking at the anti-histamine type presentations, the anti-allergy drugs, just making certain that we had something that was sensible for patients, made it easier for them to access medication, more effective for them. And that was the crux of that. And then some of them were things like atropine and pilocarpine, putting those back for the reason Steve's spoken about. Not used often, but really useful to have just in case, and with one eye on the future. And then there are a couple of weird ones when we look at the optometry ones, that because AS, and Steve said about AS, there aren't many people registered as AS anymore. I think there's 11, something like that. The department were in a position where they were moving pretty much all the medicines that were AS into core practice for optometrists. You'd have ended up with 1 or 2 random ones that they'd have only been available to AS. And they took a decision that it was sensible just to move those across. They'd be so rarely used that you may as well move them across rather than leaving them orphaned on a list. So in answer to your question, most of it practicality, fixing problems, and then a few just pragmatic approaches to make certain that things weren't left dangling on a list with nobody ever able to access them.
Steve, anything you wanted to add to that at all?
No, not really. I mean, to some extent, it's a way of future-proofing for the short term, but it can't future-proof for the long term because we don't know quite what's going to happen. And so this will need to be revisited again at some point. But trying to get anything through the system is difficult. Trying to change anything you've already started putting through the system is even harder. And so, I mean, at this point in time, if we can get through what's there now, then that will be a real win. If you add something to it, it takes you right back to square one. It's like snakes and ladders. And therefore, you have to go through the whole process again, not just say, I'd like to add one drug, but the whole process. So if it's taken us 10 years to get to this point, you won't be seeing anything for another 10 years. I'm sorry to
Thanks,
say.
Steve. That's all right. The other question that's come up, there's always the vulgar question of money and finances that come into all of this. So, a colleague has said, well, who's going to fund my training, to kind of use these meds? Where's the funding going to come through from this? I'm going to probably address that, Peter, to yourself in a wider sector point of view, because it covers pathway development and commissioning, etc., etc.
Thank you, Max. You save all the best questions for me, so I'm very privileged.
I've got a special Peter list here, Peter. So.
Oh, thank you. So it's a really good question, isn't it? And I think as a profession, we have at points been too keen to give things away, and I completely hear that. I think in the subtext of the question you've just read out. But if we want to do more, if we want to make certain that the professions that we, I think, all are very fond of are protected for the future, are embedded in the NHS, are embedded in services, and that we can do more, that we have a higher base to start from, we have to just get these skills and get access to these medications, and to make the world a bit better for us. The training for using them, if you haven't already got the core training, I'm hoping that the CPD will be available. I know Parandeep and Alex and Dean have just spoken about it. I think I've said to you before that we're very keen that we look to the colleges, and it's important to remember ABDO are a college as well as our College of Optometrists, to put that training on, because it's important it comes from those sources. Everybody else will support, and hopefully lots of CPD will be available, hopefully by some of our IB colleagues as well, who will think, I'll run a CPD talk at my LOC event and help to upskill practitioners. So hopefully the cost won't be huge for anybody, but the opportunity is. And that's why I think we need to just not focus on the money too much, because if we get all of our practitioners moved up to this level, they can do so much more, we can aim to build so much higher. And in 5 years from now, hopefully we can start talking about things that at the moment are too difficult to do. But in 5 years, if we've raised the base, then hopefully they're not.
And just to add in, really from my perspective within ABDO as kind of as a support and run the extended services course, which allows contact lens opticians to do some additional training to go and complete the WOPEC modules, and we can get involved in Qs and MECs, foreign body removal, GAT, etc., etc. It's a bit chicken and egg, in an area where they want to run these services, they need to have the workforce, and they won't commission unless we have the workforce. So sometimes it is a kind of a leap of faith to invest in your own kind of professional development and look to those opportunities for the future. And sometimes it really is a leap of faith, because it doesn't happen for many years. But the professional development element of it is obviously something that we as an association and the college, etc., would always say, if we want to, as a sector, to widen our scope of practice, to do more things, to get more opportunities, it is going to be around embracing this and doing these kind of stuff. CPD, it's kind of part of the course for us all as clinicians anyway. The other question,
if I may,
Steve, of course, yeah.
Is that once this comes online, people who are involved will need to do it regularly. It's not the sort of thing that you can do once every 2 years. You really do need to be doing it frequently. So having access to schemes where you can use your knowledge and skills is going to be really, really important. And there will be some groups that don't want to do anything more than they do now, and there will be some groups that want to go further, and that's absolutely fine. But the ones that want to go further will be wanting to do more and more of it. The ones that don't do it at all can't just dip in and dip out, because it doesn't work that way, I'm afraid.
Mm-hmm. An interesting question that's coming. I'm not quite sure who wishes to answer this one, but chloramphenicol as prophylactic agent post FB removal. Anyone?
I'm happy to take that one if that's okay, Max. Yeah. So it's important to distinguish between the fact that chloramphenicol is available in 2 different legal classifications. There's a pharmacy-only formulation, and that's specifically licensed for bacterial conjunctivitis only. And then there's a prescription-only formulation. Although the licensed indication includes bacterial infections of the eye, you can use that POM version off-label. So in order to access that, you would have to do that via a signed order, because those POM exemptions can be used off-label, but the P-only versions cannot. So to answer the question, yes, if you have a foreign body removal, there's a high risk of infection, and you want to provide some antibiotic cover, then it'll have to be via the signed order. And as Steve's already mentioned, you've got to get familiar with understanding how to write those safely. And as a college, we produce a template where you can actually include that information, which gives you the key areas of patients, the address, the date of birth, specific formulation, the frequency, duration, etc., and the date. So that all that information is there. You just got to be able to do that regularly, and like Steve mentioned, it's not something you just dip in and out of. In order to maintain your scope of practice, you need to do it regularly, and so that's really key to take home. But the short answer is it's possible, but you've got to make sure that before you go into the area of practice, that you're fully aware of how to manage that condition in the first instance.
Okay, thank you, Parandeep. A question here as well. I think we're probably heading to the final questions here, but more of perhaps a comment that a colleague on the call, a colleague in the audience has made is in regard to, say, orthoptist prescribing in hospitals under supervision, but an optometrist needs IP out in the community. So I think the comment is why is it different? Why is it different for, I don't know if other colleagues on the call can see the question here, but why is it different? The question is, why can orthoptists prescribe anything under supervision at a hospital, but an optometrist needs IP? Glaucoma postgrad degrees and it's still considered inexperienced by ophthalmologists. I guess the question is more around, is it a level playing field? Is this, so therefore, is this a step to try to give us more of a level playing field between colleagues in primary care and perhaps colleagues within secondary care?
I think just go on, Peter, if you want to start, go on.
Start off maybe if Paramdeep then chips in. So I think orthoptists' legal prescribing rights are actually quite limited in terms of what they have access to. There's a reduced formulary. It's certainly not everything. But when they're working in a hospital and they're working with a consultant, there are ways around that, and there are mechanisms that enable them to access certain medications. I think it's important we don't confuse those two things. Lots of optometrists working in hospital practice will have access via PGDs or similar sort of mechanisms where there's a legal mechanism for the person to provide the drug. They may not actually be the one prescribing in the truest sense of the word. And I think Paramdeep will touch on that a bit more. But your equity point, Max, a number of years ago, those orthoptist exemptions for medicines did expand. And I know lots of colleagues looked around and thought, gosh, that's great for them, but why are we not able to have the same sort of level of access to medications? Why was our list a little bit restricted a number of years ago? And this piece of work is to partially rectify that, partially to instill some parity, and actually to enable the professions to do what they can do so well, and just to give them the tools to do it. Paramdeep, do you want to come in on that orthoptist piece?
Yeah, you did cover the first point, was around it's likely that the setting that they're working within a hospital setting is very different in terms of the access to the medicines. As Peter's already mentioned, the formulary exemptions for orthoptists is very limited, but they also have different ways that they enable them to supply it. Now, for an orthoptist to supply a medicine, it's very likely to be under a PGD, which is why they can probably supply it directly, and also working under potentially a service where there's an established standard operating procedure or protocol where there is some ophthalmology oversight. So that's possibly where the confusion may have lied. But yeah, it's very clear to be aware of the different mechanisms by which you can actually supply medicine.
Okay, lovely. So I noticed we're coming into the last couple of minutes of the webinar tonight. Is there any final comments from any of our panel members that they wanted to share? So,
the only thing I would add is that it's just really to back up what Steve had said at his point. I think it's really important that we try and engage in this process. And yes, there's a small number of us on this webinar tonight, but you all know colleagues, you all work with colleagues. Please encourage as many of them as they can to complete the consultation. I believe it's in the chat now, isn't it? I think Sue's put in the chat. So you look at in the chat part of it, you'll see the link to it. If you can find a way to copy that, open it up on your browsers, copy it, if you can send it to your colleagues. At the end of the day, this is about how we can benefit the public more, and it's a really good opportunity.
Yeah, thanks, Dean. And there's a comment on it from Fanula, an LOC chair, just saying thank you to all of the people who've worked so tirelessly to kind of keep this going. I mean, it has been a labour of love over many governments. Not, thank God, many pandemics and not many Brexits, but it has carried on throughout. So just to share those thanks there, and it was a plea to please do encourage your colleagues to respond to this consultation. I'm sure there will be people who'll be responding with queries, with challenges, etc. And the voice of primary care clinicians and registrants needs to be heard, because there is a huge opportunity here. And I think one of our colleagues from Optometry Wales has put it here, it is a chance in a lifetime to make some different changes to what we can actually do in practice. So I think with that, I think we've covered off as best I can see all of the questions that have come in. So what I'd like to do is thank my colleagues on the panel for giving up the time tonight. Thanks to Sue for working in the background to make sure that people came on and people left, and questions were able to answer, and somebody was able to post the link to the consultation, which was beyond my expertise. And thank you for everyone who's turned up tonight to join us on the call, and very much look forward to seeing more people out in practice in the future, and for everyone taking part in the consultation, and hopefully for a positive result. So thank you everyone, and good night.
Everyone.